Yeah, thank you very much. And we formally begin with our session. And I'm really thankful to all the panelists who are joining me. And I'm really thankful for my co-moderator, Anath, who's really very, kind and who, took such a pain to, organize all those things. Thank you very much. And Anath, how do you want to start it?
I'd like to start with saying hello to everyone, and I see a big group saying hello from a Safar of Hospital in Israel.
Hi.
So I think that we are really multi-Israel India national in the sense that we have a team in a Safar of, which is center of Israel. We have Professor Ifergan from south of Israel, from Beersheba, the city of Beersheba. We have Raviv Byron, president of our Israel-India Chamber of Commerce based next to Tel Aviv. Naveen, you are based in Delhi, I guess, right?
Yeah, Delhi, Gurgaon, Delhi, NCR, and it's very much Delhi, you can say. Yeah.
Neeraj is in Bangalore.
Hi.
So I'll introduce Neeraj and Anjan because Neeraj and Anjan Da is our kind of our mentor. Anjan Da is a veteran, and he has contributed in a big way to Indian healthcare industry. And he was heading Philips in India, and Neeraj is a good friend. He's vice president and cluster head of Rainbow Children Hospital Group. So we are formally introduced to to each one of us, and I would like Anath how to take it forward.
So I'd like first to introduce the two speakers that I have. But before that, we have Mr. Barak Granot, which is the commercial attaché of Israel.
Yeah.
Although he is usually in New Delhi, he is presently in the north of Israel. Barak, why won't you say a few words?
Just quickly, would like to say thank you, Anat and Raviv from the India-Israel Chamber of Commerce, and to the Voice of Health, and to the honorable speakers and the Israeli companies. I don't want to take much of your time, just to say that we, as the Economic and Trade Mission at the Embassy of Israel in New Delhi, are here for you in order to connect to Israeli companies, entrepreneurs, innovators, academic institution, whatever you need, we are at your service. Just reach out to us and we will scout for you the relevant Israeli companies and find for you the relevant Israeli solutions. That's it. Let's have a great seminar. Thank you.
Thank you.
Thank you, Barak. And I'll hand for a few words of welcome to my colleague Raviv Byron, the president of the Israel-India Chamber of Commerce.
Thank you, Anat, and thank you, everybody. Dr. Naveen, who's organized it. I'd really appreciate the fact that you've organized it. I think there's a lot we can learn from each other. India, I've been active in India for the last 35 years, and I've seen many, many changes come to India in that time. Much of the time I'm based in Mumbai. And I've seen particularly the huge changes in the hospitals in India. Today, there are many, many hospitals in India which are world-class standards with professionals, doctors who are definitely world-class standard plus. And so this is a very, very important sector in the Indian economy, in the Indian society. And I think we can learn in Israel a lot from India. I think Israel has made a lot of advances in healthcare as well, and we can give that benefit from what we have. And I think this sort of a combination, joint venture between the two of us can be of huge benefit to the whole world. So thank you everybody for coming and for joining us, and thanks for the participants who I presume are listening, even though we can't hear them. And have a great seminar. Thank you.
Thank you.
I'd like to present the team in a Safar Ofe. We have with us Dr. Osnat Levtzion Korach. which is the Director General of Asaf HaRofeh Hospital. We have in her team Mr. Ilan Iftach, the Administration Director, Engineer Eli Cohen, Head of the Building Division, Engineer Yaakov Shalom, Head of the Medical Equipment and Technologies. And I think I've missed someone in your team, so if you can present yourself, because
No, all is good. Ilan, Eli, and Yaakov, and myself, we're all good.
Okay.
Very happy to be here.
So thanks for coming, all of you. It's really appreciated to take the time for you to join during those times. And we have, as I said, in the south of Israel, Professor Ifergan. And I'd like to start with you, Professor Ifergan, if you can. How many people are watching us now? Naveen, do you know?
So 40 people on this webinar, because we make it Facebook Live. So every time, whenever we go live on Facebook, more than 1,000 people view us.
Okay, so
we'll have to speak something wise, to say something wise.
Yes, that's a challenge. Yes.
That's a challenge, yeah.
Just to present you, Professor Ifergan is a clinical neurologist, active researcher, graduate of the Ben Gurion University and Soroka Medical Center, which is one of the leading medical centers in the south of Israel, catering to a big community that resides in the south of this country. He served as deputy director of the medical center until a few years, and now he is heading the neurology department. And he actually started the brain medicine division in his medical center. So I would like to ask you, Professor Ifergan, and to all the Indians that join us today, Israelis, we call each other by first name. So it will slip to me that I'll call him sometimes Gal, and apologies. Professor Ifergan, though, can you describe a bit the Israeli medical system, the health system, so that our Indian friends would know a bit more about us?
Okay, so the medical system in Israel is mostly public, based on mandatory health insurance law, health coverage law, which every citizen is entitled to, and every citizen is paying based on his salary. And the delivery of care is done by 4 major HMOs. That 4 HMOs, 2 of them are very big, 2 of them are smaller, and every citizen chooses to which HMOs he or she belongs. And the payment is transferred by the government. Care is given either in an ambulatory setting with primary clinics and specialist clinics, which are in the community, in the control of the HMOs, and by a hospital system which delivers inpatient care and outpatient care in specialized clinics inside the hospitals. Those hospitals are divided, about a third of them is owned by the government, another third is owned by one of the HMOs, the Clalit HMO, and others are either by another HMO or semi-private settings. The coverage is basically decided by governmental process, by the Department of Health. There's something called the health basket that is updated every year and it determines to what services and technologies patients are entitled. Israel spends about 7.5% of the GDP on health, which we consider to be low compared to other OECD countries. Has lower hospitalization beds, a lower number of hospitalization beds. We are talking about 3.1 physicians per 1,000 people and 5 nurses per 1,000. So compared to the OECD, we are not in a very good place. Now, the Israeli system, Israel, you probably see it as a very small and condensed country, but for us, there is the center of the country and the periphery. And in the periphery, what we call periphery, for you is next door probably, just for proportions, Beersheba, where I practice, is 90 kilometers from Tel Aviv, but it is considered to be a periphery. And we are a single hospital in our setting, 1,100 beds, tertiary hospital, trauma center, and whatever. And we are the only hospital covering the entire population of the Negev, which is somewhere between 700,000 and 1 million people. And that's the setup I'm working in. In the center of the country, there are many more hospitals.
Yeah, like Asaf Arofeh, exactly. Thank you, Gal. And Naveen, I would appreciate if you can give us a short introduction of the Indian health system for our Israeli colleagues that are watching us now. No, we can't hear you.
Yeah, so I mean, we are a bit at a contrast. If I compare India with Israel, we are, I mean, most of the services are private. So, you know, India is a big country of 1.3 billion people, and it's divided into 28 states, 8 union territories. And in India, health is the responsibility of state. It means it's a state subject. Healthcare services are largely provided by private healthcare service providers, which is up to 70% of the services, while government's contribution is limited to somewhere between 20 to 30%. So you can say that government is mainly acting as a regulator in this country. Private players are playing important role in keeping people healthy and safe. Most of them are single doctor owned clinics or nursing homes. And there are a couple of large hospital chains in the country providing tertiary and quaternary care. If we talk about government infrastructures, we have more than 700 district towns, and every district town has a population of around 1 million people on an average basis. Usually there is a civil hospital in every district town, and this hospital has a capacity of up to 100 or sometimes more than 100 beds. And these civil hospitals, they provide all sort of secondary care services and low tertiary care services as well sometimes. When we go down deeper into tier 2, tier 3 towns and villages, there are community health centers, primary health centers, sub-centers run by state governments. Affordability is another challenge. 70% of people pay out of pocket for almost all healthcare services in India. The challenge of affordability is being solved by the recent scheme launched, PMJ, we call it Ayushman Bharat scheme, which is the biggest scheme in the world. It's a kind of a social scheme where more than 500 million people are covered, and coverage will increase with time, and more people will come under its ambit. I will discuss about other resources as well. There are around 1 million doctors in India, which is a way less than as per WHO guidelines, which says that we should have minimum 3 doctors per 1,000 population. And we have around 1.8 million nurses, 200,000 pharmacists. Again, we have a limited manpower, limited resources if we go by WHO guidelines. I don't know the exact number of beds we have, but to what I believe that we have around 1.7 million total beds put together, government and private, out of which 125,000 beds are ICU beds. And if we go by the formula that there are every second bed has a ventilator, then you can say that we have 65,000 ventilators in the country, out of which only 40,000 ventilators are the functional one. Government spending on healthcare in terms of GDP is limited to, you can say it's only up to 1%, which is much low if we compare it with other countries. Healthcare has always been on the back burner, but with the current crisis, I hope healthcare will get some priority in coming time. So that's in a nutshell about Indian healthcare system.
Thank you, Naveen. Before we go into the topic of our session today, efficiency in hospitals, Professor Ifegan, I have a quick question to you, and then I'll hand it back to you, Naveen. The corona situation in Israel, if you can give us quick vital statistics.
Well, the corona crisis actually passed here relatively well. We have in the entire country, we have somewhere around 250 cases of death and about 15,000 confirmed cases. It changes every day how to keep track. Most of them have already recovered. So basically, and it seems like we passed the first wave of that, but we are still looking forward for what's going to happen and gradually opening the country, and every day or every week, some other sector is being opened. Generally speaking, hospitals in the first phase, in the first few weeks, limited their services in other aspects, and patients also didn't come because they were because of social distancing policies and fear of getting infected. But the patients gradually came back, and now we face the full burden of patients that we usually see, even a little bit more than usual. After big campaigns of don't neglect yourself, come to be treated, and gradually the patients are coming back.
Thank you, Professor Ifegan. I'd like to ask the same question to you, Mr. Boss. Can you update us on the
yes,
on the corona situation in India?
Sure. I would say, just as a start, am I audible?
Yes, you are.
Yeah, audible.
Okay.
Yes.
I would say that all the activities that world is seeing and India is seeing, there's a lot of clutter and noise. But I would like to categorize as respond, reset, and rebound. We are going through the process of responding now, the whole world and India certainly. After this, we'll come to a situation when this will pass, we'll have to reset ourselves, our life, and we have to rebound by making business continuity plans and stuff like that. So for challenging corona in India, I think corona warriors today in India are responding to the critical, this uniquely difficult challenge through various means, stakeholders, government. You heard from Naveen the complexity of our healthcare system, 130 billion people. So we have government hospitals, central government, states. By the way, states, the word can be confusing. State in India means the provinces, the 28 to 30 provinces. So central, state government, private healthcare, NGOs, media, think tanks, doctors, nurses, biomeds, paramedics. You can imagine for 130 billion people, how many stakeholders are there, all responding to this sudden shock that the world is facing, and which has created havoc. We all know it has stopped flights in India also, trains, no buses, stopped sports. Wimbledon has been cancelled for the first time. Olympics will be cancelled. And for those of you who may not know, India, in a cricket-loving nation, there's something called IPL, the league right now. Postponement of that is like a national crisis. I wanted to mention this general thing because day to day we are immersed in this situation. So how did India, the corona warriors or corona scorecard look like? How did we do? This is from the latest World Health Organization approved site. I'm mentioning this to avoid controversy. 46,437 confirmed case this morning, 12,847 recovered, which is a recovery rate of 27.7%, pretty good. 1,566 unfortunately deaths, which is 3.4% fatality rate. That's also, death is never good, but it's pretty much in control. And the daily confirmed case is now 34 per million population. 34 per million population for a 130 billion, the number is still in control. So you imagine a country like India, which from west to east, it is like, from Bengal to Tamil Nadu is like Bulgaria or Yugoslavia to UK, and north to south, Kashmir to Tamil Nadu is Finland to Italy. Sorry, west to east was like Bengal to Gujarat. So it's a huge country. It's of the size of European Union almost. So if you look at the numbers now that India I just articulated, and if you compare with the numbers of the European countries, even US, I would say Indian numbers have been pretty much in control. And what are the key reasons that many of us think? Number one, for a complex country of the size of EU and diversity, there were very decisive actions by central government and very strict lockdown right from 25th of March. It's continuing, and most of the states will perhaps continue till the end of May. Very strict. It's incredible the way it has been implemented. Number two, the spirit of togetherness. Let's not forget the soft points, this cooperative federalism, as our Prime Minister says very rightly, we are one nation in the time of calamity and adversity. And this is amazing. India is full of politics and diversity, but whenever a calamity hits us, we must win over. The new enemy is the spirit. I think that's a very important second reason across the country, including media. Number three, general response has been pretty disciplined from the citizens, which is amazing for a country like us, pretty disciplined. However, I will mention three challenges and then stop. The three challenges that I felt was addressing the needs of the migrant population. Those who live in India from Israel know across the states, millions of migrant workers wanted to go home. That's not easy with closing of the border states. Challenge number one. Challenge number two, you heard from Naveen, the diversity and differences in healthcare management infrastructure amongst the states is very wide. It's not one country. It's like Italy, Italian health system, UK health system, Finnish health system. Look at the number in Kerala, one of the most progressive states. They were number 2 for 2 weeks. Now they have come to the bottom. They have almost flattened the curve after the initial outburst. Healthcare infrastructure is very high. We have the reverse also in some of the states and provinces. Number 3, and the last one, I think the challenge has been, unfortunately, some initial spread through unfortunate, unwarranted, undesired large gatherings. Some of them social, some of them religious gatherings, which quickly spread the coronavirus. Otherwise, Indian numbers would have been smaller. But, and I conclude by saying that we are happy that Indian technology is so strong. So through technology like Arogya app, you can all download, even Israeli citizens can download. Arogya app is one of the fantastic COVID trackers that I've seen anywhere in the world. So these large gatherings, while they spread it fast, they were tracked also fast. I would say pretty good performance so far. Thank you.
To our team in Asaf HaRofeh, headed by Dr. Osnat Lev-Zion Korach. And I would like actually to introduce you first, Dr. Osnat, graduate of Hadassah University Medical School. Thereafter worked in Harvard, Boston, and Boston University, came back to Israel and was the director at Hadassah Mount Scopus Hospital in Jerusalem, and became the Director General of Shamir Medical Center of Asaf HaRofeh in September 2017. So you're less than 3 years in your position, and suddenly this big challenge comes across. Dr. Osnat's specialty is pediatrics and hospital management. So Osnat, I'd like you to talk about your hospital and how you prepared or is prepared to the corona pandemic.
Thank you, and thank you. We're very happy to be here. And because the corona is a very big logistic challenge, a little bit of 2 words, we are a 900-bed academic medical center. And as Gal said, we are in the midst of not far from Tel Aviv, the closest to the airport. Very happy to be here. And I think we're very happy to learn from each other. It's fascinating for me. So what are the main challenges with this corona thing? One of the main challenges is to prevent our teams from being exposed. And that's one of the main thing, because if we want our teams to work and they have to feel safe. One of the issues was the PPE, the personal protective equipment, which Ilan, the administrative director, will talk about. That's one of the big challenges. The next thing is we wanted to be, talking about the equipment, we needed to be, so they'll be able to work with it, comfortable as much as it can be. And communication is a big deal, which we'll talk about later too. The next thing is one of the things that we need to know, we need to differentiate between the corona patients and the regular patient, the non-corona. For that reason, we had to change the emergency department to different departments. We had to prepare a special patient flow for each of the unique patients, whether it's the operating room, whether it's the cath lab, whether it's the neuroradiology, each delivery room, pediatrics. We had to find a way and a flow to each group of patients. Aside from that, we built the Shamir Corona Center, which is 86 beds. Eli, our engineer, will talk about building. There's tons of building involved in this preparedness for the corona. One of the things is, and what Gal referred to, is how to try and get the patients to come, because we know that there was an increase in the number of patients dying from heart attacks and strokes that would never happen in a regular day, because people were afraid of coming to the hospital. The other thing, talking about medical issues, one of the things that we need to know is how to get, when there's the COVID-19, doctors and nurses always, you're all toned to think about that. And sometimes mistakes are being done because people forget the regular medicine. And as leaders and hospital managers, clinical hospital managers, we have to try and remember how to get the physicians not to think just corona, because still there are other things that can happen. Another issue which was a challenge is how do you speak with the patients? How do you communicate? One of the things that happened in Israel Hospital, which is a brilliant idea, was to put pictures of the staff on their gowns, because with all the face masks, you don't see anyone. And for the patients, everyone looks the same now. So just put pictures. We put the pictures of the staff and picture and name, and that was brilliant. The other thing is, how do you communicate with families? So we used the phone. We used another technique that we'll talk later from Elby. And how do you communicate among the staff? Do you allow families to come in to say goodbye to dying patients? It was a big deal. And then we decided that in some instances, we're protecting them if the family wants, and 1 or 2 can go in, but it's a very, very big, challenging thing. Innovations. You know that Israel, we're being called the startup nation. A lot of innovation has come around the corona. Different high-tech companies joined hospitals, and a lot of very, very good things happened from it. Medically, I just want to note that what we found very effective is giving plasma of patients who already recovered, which contains antibodies to very difficult patients and complicated patients. And luckily, we had very good results with the plasma. But I can tell you that medically, it's a very bad disease. For most people, it's really very mild disease, but if you're very sick, then you're very, very sick. I think at this point, I would like to go to refer to my colleagues to talk about all the logistics aspects. We would be happy to. We have very short amount of time, but we're happy to answer any questions you can send us emails, phone calls, whatever. We're happy to share. We're dealing with it. So it's a big deal. We're happy to share.
Okay. Okay, from the logistic point of view, two things that I will mention. One, it's very important to do an operating plan for each stage of the plane and to be ready for everything that needs for this kind of stage plan. The other things that I think it's very important is the protecting and equipment that the staff needs for each stage. And when the staff is in a mode that it's okay with the equipment, so I think the treatment in the patients get more easier. So the most unwanted things that will happen, that the staff will be without the equipment that you need to take care for the patient. So it's very important to do it. And in the situation that in the whole world, the hospitals needs the same staff, so it's a big challenge. And it should be taken before and ensure that the equipment is in your hospital. Otherwise, it's a very big problem. Communication is the last one that I will mention. The communication in the hospital and in the units, it's very hard to do with the equipment, and there is a lot of solution for that to get over the challenge and the problem that it's going. And there is two companies in Israel that we are working with that provide us a solution to this problem, because it's very needed in the cases of treatment with the coronavirus patients.
Ilan, just to interfere, at the end of this session, we invited VP Technologies from Elbit System that works with you to present his solution. Yeah. So we will give a live example of the solution that you are using.
Okay, that's all for me.
Okay, hi. Thank you for listening to us. For me as an engineer, the first thing that was very important to us to adjust our department is to have the outline of the transmission assumption. And this is the first thing that we try to do with our professional people. And since we got the assumption, this is not assumption, it's that this is a droplet or contact isolation, we can now start to figure out and design our department and converting our wards according to this assumption. And this is very, very important that you had this assumption. I wrote some things because I have a very short time topics for how we rearrange our department. Well, first of all, the first thing is to have a clean and dirty area. The second is to have protection, undressing and protection dressing for this, to take the gowns out. Other thing is we have to figure out the patient flow, the staff flow, garbage, waste, everything has to be figured out, designed, and the department has to be changed for in this according to this design. All the doors that are being, we put some controller to have authorized access doors. We have, for the staff, we have a control center. The control center is designed to be in the clean area. So the people, the staff, the doctor, the physician, and the nurses could operate everything without have to have the PPE because it's very, very hard to walk with all the masks and the gowns. So they were located in a clean area. According to Minister of Health, if we have people who needed the ventilators, we needed to have a negative pressure in the room. So we had to adjust also the rooms to have a negative pressure. We didn't have to have filters in the room, only a negative pressure. And this is a discussion that we had, and I think they will had it till now. But the instruction that we have given is only to have a negative pressure. Another thing that we have to arrange very, very quickly, because of the ventilator, we had to have a lot of, we have to purchase a lot of biological hood for all the blood gas tests. It's something that if you have to prepare, especially in a country huge as India, so we have to prepare it in advance because it's not in the market so easily. The second thing that we have to arrange is the flow patient. As we mentioned before, we had a suspected coronavirus and a non-suspected, and we have to verify or to realize how we do it. So we have to change all the flow in the ER department, and we divided the ER department to suspected and unsuspected, and we changed the flow for the patient, for the ambulance. And in the suspected area, we had two wings. One wing was for the respiratory people, and the other was for people who arrived with the ambulance and already ventilated. And they were in private rooms with negative pressure. And we also, although it was just a recommendation, we had in each room a HEPA filter, although we're not sure if it's proven already, but we had a HEPA filter in each room. And we changed all the curtains that were in the hospital, in the ER department, to washable barrier. It was something that it was very difficult in each patient to take the curtain out to wash it. So during the pandemic, we changed all the curtain to washable barrier. And this is the things we did very quickly in the ER. In terms of infrastructure, in each department, we had to put a lot of, or to enlarge the computer communication cables, because we use it for camera, we use it for remote monitors, we use it for video conference. And we had to also to have a negative pressure in most of the wards that are designed to be for ventilated people. The fourth things that we had to take care into consideration is the large amount of oxygen consumption. During the guideline that we had, that we will have a lot of people that will need a ventilator. So we had to figure out if we have the oxygen, first of all, to figure out how many ventilated people we will have, what will be the consumption, and we have to do an analysis to the oxygen supply chain to see if we have any problem. So it was a big issue in Israel. During the pandemic, the Minister of Health had a small committee, and we tried to figure out, first of all, what will be the quantity for ventilator people, what will be for people with non-invasion consumption for oxygen. And after we figure out, we have to evaluate the numbers, and each hospital have to prove that he has all the infrastructure for providing the oxygen consumption. So it's something that we had to do during the pandemic.
And I'd like to thank you. I'd like to take a minute and share with everyone a clip about the Asaf HaRofeh Hospital. And you can continue talking and explaining to us in the background what we are seeing. Let me do a share screen with you. And let's try to see this.
Of our hospital, driving. The ambulance is
Leading.
is taking a corona patient, and this is the corona center. That's in Hebrew, of course. This is the control center that Eli was talking about. This is the area where they dress up. You see the family. You see the picture of the worker on the screen. Here they see each and every room, and one of the things that we talked about innovation is the robot that can help in the rooms. As we want to minimize the number of contact, the time of contact between the staff and the patients. One of the things that this is just this labs, which is, again, we didn't talk about it, but the labs, the screening, the RT-PCR is was a big deal in Israel, and also poses a challenge: who to screen, who to take the tests for. This is the emergency room staff. One of the things that we are very keen about is all the staff are with masks, not just N95. Even people who are all around the hospitals are with staff. This is the OR that is, we had to operate on corona patients. So this is how it looks.
I see.
And you see, this is the ICU. Again, this is the, we had to upgrade some of the rooms in the Corona Center to be ICU applicable, almost ICU. This is it. I would like now to let Yaakov talk a little bit about what do you do, because it's a very important thing, the equipment.
We have really a short time, Yaakov, so if you can really
very quickly. I speak about the medical equipment. First of all, it's very important to understand what is the actual status of the medical device in your hospital. For me, the most significant challenge was to equip the department of the corona ventilated patient, of course with ventilator, but not to forget also monitor, including capnography, infusion pump, syringe pump per patient, and also take care of the medical equipment for the department. So it will support the treatment in the corona department itself. We don't want to let the patient outside the corona area. Therefore, we managed to equip with mobile DR X-ray, ultrasound, echo, blood gas analyzer that was mentioned before, and also the regular stuff for the department, such as defibrillator, ECG, blood pressure, and etc. One thing that we take into consideration is the adjustment of the infrastructure and communication. So we'll get monitor central station and also video central station that allows us to get a good idea about the situation of our patient when the staff is outside the corona area. I'll switch to the conclusion. The key point: be proactive, always cooperative, and be in touch with the medical staff in the field and address the dynamic needs. Thank you.
Thank you. Thank you. I thought of saying it at the end, but I think that both Asaf HaRofeh Medical Center and Soroka Hospital are looking for collaborations and exchange with Indian hospitals and clinics. And I hope that this session today is just the beginning of the dialogue. And we will be happy after that to exchange and give information of each other. And Naveen, why won't you take the lead from here?
Thank you very much. I think there is a lot of progress in Israel, and what I heard from all of you, it is, it's tremendous. And the way Israel is dealing with all these patients, coming up with new therapies, treatment. This morning, I got another news that Israel has, got the method how to, produce monoclonal antibodies, which will replace plasma therapy ultimately. So I think you are on the right track, and a lot of good things are happening. And I'm sure that Israel will be corona-free very soon. But at the same time, we in India facing a lot of challenges in terms of, we are getting a lot of cases. Suddenly, for past 4 or 5 days, we have started getting more and more cases. Although our governments are working day and night, central government is supporting all the state governments, and state governments are also working day and night to contain and control the disease. So I would come to you, Mr. Anjan Bose. What do you think? I mean, how can we, what all steps we should take to contain this? And what has been, what all steps have been taken so far? So what is your take on it? Anjanda, over to you.
Thank you, Naveen. I came prepared with a 3-minute monologue based on the mail that you had sent.
Thank you very much. Thank you.
But with you, always a surprise, pleasant surprise. So I'd like to respond to that. It's a very good and relevant question.
So I want to know your plan of 360-degree. Basically, I want to come to that point only.
Sure. It's a good question. No, you see, the first thing is that I think the two most often heard words these days are new normal. So the first thing I wanted to say is that, we are talking about preparedness of organization. Nobody was prepared. And there cannot be any preparation to face tsunamis of this magnitude, these million tsunamis. So all I want to say is that, it is not only about hospitals facing challenges. We need to remember that healthcare is like a jigsaw puzzle. You have 100 stakeholders, diagnostic centers, medtech companies, devices, equipments, home care, health education, health insurance. I'm purposely bringing this point in this forum where the key topic is hospital efficiency, because the last mile run is through the hospital. That's when the run ends with the patient, the patient care. But the entire gamut of segments that I mentioned also constitutes healthcare, and therefore success or failure of a fight like this, which is unplanned, will also depend on the performance of the individual segments. Therefore, let me pick up a couple of examples, Naveen, that we have all been observing in the last couple of months. A ventilator, for example. No country in the world, especially the bigger countries, were prepared to have so many. I come from medical technology segment, basically, in my early part of the career. And I'm so happy to have a lot of engineers from the Israeli colleagues, rather than only doctors dominating in the panels. Engineers are equally needed. So medtech, for example, the ventilators have been a key issue. No country was prepared. I am in the middle of companies which are trying, auto manufacturing companies, which are trying to build ventilators, but failing, leading auto manufacturing companies. So, Israel is not new to innovation. I just want to end this point by saying, like Pluto said, the famous Greek philosopher, that adversity is the mother of invention. And the bigger the adversity, the bigger are the urges to create invention. Therefore, we see all around, my friends are saying we are doubling our ventilator supply. So there are things like that which we have to continue to do. Now, what shall the government do? Government has to realize, like you said in the beginning, Indian government plays a regulatory role mainly, but they need to realize that it's time for balanced action. Like you and I have both been crusader to the government to explain to them that bureaucracy must understand that special actions needed for special times. Therefore, possibly make it easy for imports of parts, exports out of the country and stuff like that. So that's one example. Second example I'll pick up for the paucity of the time, only these two, that is to do with diagnostic centers. I just want to mention that the new normal will definitely include tremendous use of artificial intelligence and machine learning and augmented reality, which were only buzzwords before, but they are creating day-to-day solution today, Naveen. We must find every means, advocacy to the government and other things to see how those technologies can find a place in a more active way as an enabler. One example, right now, one of the organizations that I'm involved in, Silicon Valley, artificial intelligence and machine learning is being used to enhance the supply chain of some of the biggest diagnostic centers of the country. Imagine the supply chain trouble. Supply chain anyway is a trouble in India. Now trucks are stopped. The states have barriers. How do you handle it? You cannot handle it in conventional ways like we did for 100 years. So artificial intelligence and support artificial intelligence, digital technology. And the last point, if I may mention, being from MedTech, my colleagues in the hospitals, eminent hospital, Israeli colleagues will understand this. Equipment can be there, but equipments can always fail. How do you do customer support? The leading companies of the country, the leading companies of the world who are known for their customer support, how do they do that? How do their engineers grow from Delhi to Mirat? How do they go from Calcutta to a remote village in West Bengal where they will face a police force who doesn't understand this? They have been just instructed that you don't allow anybody without a pass. So I just stop here by saying that extraordinary challenges bring extraordinary capability out of people and nation. And I think we have to rise to the occasion as one collaborative team, corporate federalism, cooperative federalism, as I said in the beginning, and government also has to be part of this exercise. And I'm very pleased to conclude that we are beginning to see that, but as the poet Robert Frost said, we have miles to go before we sleep. Thank you, Naveen.
Thank you, Anjan. I'd like to pass to you, Professor Ifergan, and share with us a little bit about your hospital and the efficiencies that you have taken in your own organization. And I understand that you have low number of cases.
Okay, I'd like to speak about 3 points here, about increasing the efficiency of the hospital in those days. And I'm not going to speak about how to treat corona patients, but rather how to run a hospital or how to treat patients in those days, because basically the challenge is coronaphobia. We are all afraid of corona, and therefore we are limiting ourselves or limiting our activity in treating other patients. Right. And most of the patients are dying now from other diseases, not necessarily from corona. So the first thing I want to talk about was creating certainty to medical staffs. The uncertainty of being exposed to corona forces many of us to work differently. Inside the hospital, we created the most safe place in the hospital is the corona department. That's the safest place because that's where the certainty is maximal. You know that every patient has corona. You protect yourself accordingly. The most uncertain place is the emergency department because every patient is suspected of having corona until proven otherwise, but maybe he doesn't, maybe have something else. And in between, you have many departments that should work, that should perform surgeries, admit patients, perform other procedures. And the issue is providing them with a maximal level of certainty. So the emergency department is the place where you create certainty from uncertainty. And for each patient, you have to define, that is admitted to the hospital, you have to define the level of certainty that he has corona or doesn't have corona. And we put an infectious disease expert in the emergency department, and he determines, or by phone, it doesn't matter, and he determines the level of suspicion. If the patient is confirmed corona, goes to corona department. Intermediate suspicion comes from a suspicion place, have specific symptoms, whatever, he goes to an intermediate department. All the other people, and most of the people are like that, are considered low risk, and those with low risk are treated in regular departments with the highest degree of certainty that you can achieve. Of course, everyone is wearing a mask. and washing your hands and all that, but you can achieve a certain level of certainty by making such a structure. The second thing is telemedicine. Telemedicine is the hero of the day. I joke with my residents that we are talking about it for the last 20 years, and it was like sex in high school. Everybody's talking about it, only a few are doing it, and those who are doing it are not doing it well. And in 2 months, we did a fast-forward process in working with telemedicine, not the optimal telemedicine, but the best telemedicine we can do, because there is no other medicine today. If you want to give service to your patients who are outside the hospital and can't come to the clinic or don't want to come to the clinic, you have to work with them in video conference apps. There are many apps in the market. Choose one, work with that, work on the phone if you can't do that. We were very afraid of that only 2 months ago, when we thought that you can't do proper medicine, but you can. And actually many of my own patients are saying, why didn't we do that earlier? Why am I coming to the hospital every time, taking the time to travel, looking for parking and waiting in the line? It's better this way. So it's not better for everything. We should know our boundaries here, but it can work from the hospital to the outside. Inside the hospital, big hospitals are using a lot of consultations from one department to the other, and consultants can transmit infections. We did that. We spread the Teams application, and we are doing that through the Teams, looking at from one department to the other, and hardly going from one department to another. The third aspect is how you work with patients in the corona departments. And here we created cockpits outside of the department, where actually the experts, the resource that is limited here is actually intensive care specialists. And we don't want them to be exposed. So we put them outside of the departments in a cockpit, overseeing the patients and getting decision. You can replace the nurse, but you can't replace the specialist because you have only a few of them. And so telemedicine entered everything, and I think we are not going to go back, because we saw that it's good and it's working, and we are going to use it even if there will be no corona in the world tomorrow morning. The third issue is how to preserve continuity among the medical staffs, because if you have one exposure in a department, the entire staff of the department should go into quarantine based on the regulations, and the department is closed. So if you have a few departments of the same sort, then it's easy. If you have a department of orthopedics that is now quarantined, so you don't have any orthopedic capability inside the hospital. So you have, when in those areas, for example, I have only one physician who's performing brain endovascular therapies. She went home. She's not in the hospital. She only comes to perform emergency procedures. Other times, stay at home, don't come, don't get infected. The other staffs, we created capsules that don't meet each other. Either they are working in different locations, in different hours, but the issue is for them not to meet each other. My deputy was in charge of one team, I was on the other team in the department, and we didn't meet each other for more than a month. And every team work is done by exactly the same technology that we're working with now. So we actually created an atmosphere of working in capsules, of operating the teams from the distance, and therefore preventing the catastrophe of having an entire team out of the game and then losing a major capability. The last thing I wanted to say, something about the soft side.
Gal, please.
About the soft side, managers must speak to the teams, speak to staffs. We have to communicate ourselves We have to, in this climate of uncertainty, we have to create the illusion of certainty by telling everyone what is going on, either by emails, by meetings, by virtual meetings, and communicate. Thank you.
Thank you, Professor Ifagan. We haven't heard Niraj all this while. Niraj, I'm handing the mic to you.
Yeah, hi. I'll just tell you my experience in running mother and child hospital, what we have done, how we have pulled in resources, and how we are fighting this COVID. See, what we have done, the biggest issue when this COVID came to India, the biggest issue is PPE. Everybody is charging more for PPE. So what we have done, 7-8 private hospital in Bangalore, we have created a consortium, and where we have done a pooling of PPE so that we get one of the best rates. Because all these suits, all these caps, masks are very, very costly in these times. And since we run a mother and child hospital in different parts of India, including Bangalore, Delhi, Chennai, and so what we have done, see, our most important patients are mothers, because you cannot stop the pregnancy, whether it is a COVID time or what. So what we have done, we have connected all our mothers through a various platform like Zoom and Microsoft Teams. So our birthing classes was happening on a Zoom, and we have seen the attendance of the pregnant mothers coming on Zoom meeting for a yoga classes is more. So our pediatrician, our obs and gynecologist is coming, and best part is that their husbands is not participating in the meetings when we used to call them in the hospital for a yoga session. So now when they're all at home, the husbands are also participating in that. So that gives a very, very good, we are at their homes, our doctors are talking to the wives, and husband and daughter and son, including grandmothers, are participating. So it is a family time with them. Secondly, what we have started, there are around 400 private ambulance driver in and around Bangalore, and they need to transfer the patient from different part of Bangalore and Karnataka to the hospitals. But it is a very, very tough time. Whichever hospital they go, they don't accept the patient. Screening process is happening. So we have taken a Zoom session for all these driver divided into 2 parts. We will explain them what are the things to be done while they hand over the patient from one part of Bangalore to another part, because those people don't know all these techniques. And we have created a triage room where any patient, we have stopped all the check-in of the hospital. We have got 4 check-ins. What we have done, we have created only one room where everybody, including the staff, doctors, and the patients coming to the hospital, there is a screening room where is a mandatory 40-minute screening is done based on certain parameter, which is given by Government of India, and a war room in the state of Karnataka, and we are doing that. Thirdly, the important part, what we have done, like you're talking about doctors and staff, we don't want every doctor and staff to get exposed. So we have given them 3 days duties. We have divided the doctor team into 2, Unit A and Unit B. Unit A is working from Mondays, Wednesdays, and Friday, and Unit B is working on Tuesdays and Saturdays and Thursdays. Similarly for the staff, so that if at all some patient or doctor is exposed, so we have one more team ready for that. So these all things we have done, like aggressive use of mask. See, the people who are not exposed to the patient, they cannot use the surgical mask. In hospital, there is a tendency, right from the manager to a housekeeping to attendant, use the surgical mask, which we want to give reserve for our doctors. So what we have done, we have purchased a cloth masks, which we have given 2 of them so that they can use them and they can wash and come back again. So these are the few things which we have done. Our 30% of the physical consultations, we have converted into a video consultation where our Microsoft team is used, and our 30% patients are coming on a video consultation. In case somebody require a physical consultation, we are using our CAPS services, where we used to issue the pass to a particular patient. They used to come and see them. So these are the few things which we are trying to do. And I think for the last 1.5 months we are doing, now we get to know our doctors, our staff get to know how we are doing, and we are managing our hospital well. I think we have to stay with this COVID for a long time. Like COVID-19 is there, maybe COVID-20, 21, and 22, and so on.
Yeah.
Thank you.
Thank you. I think we have 2 more topics that we would like to touch. First is future and lessons. I mean, taking lessons from the past and looking forward. And I'd like to pass the mic to you, Dr. Levtzion, and your team. what would you do differently in retrospect, now that you have almost 2 months of Corona experience? What would you have done differently, and what's the plans for the future? We are told that we're expecting a next wave, maybe in November. To you.
I think one of the things, I agree with what Gal said. I think that's not a lesson, that's what we did here. I think leadership that's the place for leadership. A lot of going around, speaking with the people, reducing the fear, because at first, of course, everyone was very peaceful. The other thing is, because we are expecting, we're a huge wave of a lot of ventilated patients. One of the things is start already teaching those who are not usually ventilating patients, not the ICU doctors, but building platforms in order to teach and educate and train the various physicians on staff to be able to do ventilations, which is very, very important. The other thing is working in capsules and being and the protective, and innovation-wise, think of how do we prepare ourselves stock-wise, machine-wise, and equipment in order to be able to treat all the vast number of patients. And the main thing we need to remember is what all the things that we need, all the world needs. So one of the other things that we're doing now in Israel is starting to manufacture whatever we can manufacture in Israel. We need to do it here, whether it's masks, whether it's ventilators, because we know that you can't get it anywhere in the world. There's embargo of different places. America, they can't sell out of the States and other places as well. So whatever you don't make for yourselves, you just won't have it. And the other thing is anesthetics and sedation medications, which is already it's already very hard to get all around the world. And this is something we need to manage. Each hospital needs to manage this very carefully and understand that some of the medications that usually you can treat routinely, you can use, without any limits. Now you have to limit and think very wisely of how to use it.
Thank you. Niraj, a question to you. In the future, when we don't have Corona, what things from the Corona times you would take to your daily life in the hospital?
I think social distancing is key. That's very, very important. See, Indians, whenever they meet, they used to hug each other and all. I think social distancing is a key thing which we have to make. And I think pooling of the resources. See, I think pooling of resources is very, very important. In any typical city, there's so many private hospitals. And I have seen, once I was doing a negotiation for my hospital, I'm getting a mass of ₹10. But when we all 10 hospitals join together, we get a max of ₹4. I think that is very, very important. And that is with Corona or without Corona. I think it is also take care of a bottom line of the hospital. And thirdly, I think which is most important is that whenever, because now something known as we know the patient is, in the quality we used to say universal precautions. So I think each and every patient used to treat like a universal precaution, and the mandatory checklist, they have to pass through a checklist before operating or doing any procedure on them. So these are the few things which we take away post-Corona time as well.
Thank you. I'd like to present to, unless Anjan or Gal, you have any comments to this lessons session part, I would go to the two technologists that are with us today. We invited Mr. Chaim Teichholz. You can open your camera, Chaim, and also unmute yourself.
Yes.
Chaim is VP Technology Commercialization in Elbit Systems, and you were recommended to us by the Asaf HaRofeh team that your technology was quite important to the efficiency and to the operation of the hospital. And Chaim, can you present in really 3-4 minutes your technology?
Yes, hello everyone, and thank you for the opportunity to speak to all of you. I'm actually representing the technology part in this discussion. This is how I feel, and it was very interesting to hear all of you and the big portion that you gave to technology and to the assimilation of the technology into the hospital. As someone who comes from the defense technology, and since 2 months ago, we never met a hospital, we never were aware of the hospital needs. We found out with the help of our partners in the Asaf Harofeh hospitals that basically there are a lot of similarities between the challenges in the defense area and the hospitals and the healthcare in general. So we slipped into this in very easy and smooth way, together with the Israeli style to do things very quickly, short loops, and basically come with all the power of a big technology company into the healthcare system of an hospital, Bnei Zion. And we found out that basically we built a very good solution that can help and advance the whole system in a very significant way. So, so actually I'm talking about collaboration. That was mentioned in many different ways here, that collaboration, communication, control, all of them are very crucial to effective and efficient and even life-saving way of handling the patients. And what we found out is this area is not very well handled in the hospitals. Actually, it's like a greenfield. Communication is not a big deal till the Corona crisis came in and basically showed up that communication is important because you have a lot of limitations, lot of challenges that basically you cannot meet without having a proper communication infrastructure, including the telemedicine and everything. I will show you very quickly a presentation, what we do, and yes, it will take just minutes. I hope you can see that. So when we talk about the need, okay, so there's a lot of need to proper collaboration and communication in the hospital. This is a very chaotic environment. A lot of different organizations that need to run operations, the task forces, many people in the teams, many organic and inorganic teams, and all of them need to communicate. And in the specific COVID-19 situation, where the departments are closed, where people are under protective gears, etc., basically communication and collaboration between the teams go down to close to zero, and they must have a solution. So for that, we actually use what already existing solution that we use for defense, for armies, because this is the same challenge. Also in the army, collaboration is an important need. And we as industry already invested a lot to build the proper solutions for that. And basically, to give you just a brief of this solution, this is an application. This is an application on a mobile phone. And once you install this application on every team member on his mobile phones or on organizational mobile phone, suddenly everyone can collaborate, everyone can communicate to each other, and all of that in a very controlled and effective way. So the hospital can manage that. You have in a control room, you see where everyone on the map, and you can create groups and communication groups, which are very essential for proper communication, all of that from remote. Actually, there are many use cases in the hospital, how they use that. And here you can see a little bit of the screenshots, what you see on the screen, but it's video, it's voice, it's text, it's location on a map, it's location inside the hospital, in which department, and you can solve problems like, I need an expert doctor to help me here, and you just ask for the closest one, and you'll get connection to the closest one. You can create a video session between the doctor and the patient, etc., etc. Of course, in few minutes, I will not describe the features and everything, but we found out together with the hospital team that there are many use use cases and problems that a proper communication solution solves. And actually, it's a communication infrastructure that you can hook in many other solutions, point solutions that you already have in the hospital. So this is sensors and monitors and everything actually connected to one communication infrastructure. So basically, that's the solution. Just to maybe finalize with saying that we do have. I just saw the comments that everybody wrote during those sessions. We do have a lot of joint activities together with Indian companies in India, and we'll be very happy to support whatever is needed by us. Thank you very much.
Thank you, Chaim. I'm handing, thanks for being also brief. I see people in the audience sending questions and wanting more information about you. I think that in our Facebook and later on we can exchange contact information of the various participants in this session today so that people can communicate with you and get the solutions from you. I'd like to hand the mic to you, Tzvika Agassi, CEO of Salient Eye. Tzvika, are you with us?
Yes, I'm here. Can you hear me?
Yes, we can.
Thank you.
Again, you have 3 minutes to show what you have.
Thank you, Anat. Thank you, everybody, for the opportunity. I really appreciate it. I am the CEO at Salient Eye. Salient Eye is a startup, 5 years old. We also, like Elbit, started in the security area. Our customers are security companies. And in the last few months, we have made adjustments to one of our products to the area of telemedicine. There are many other solutions in this area. We have a system that allows any hospital to have video sessions with patients with a few advantages. First of all, no app is needed. So anyone that is calling to the hospital from our system, you can turn his cellular phone call into a video call very easily. It's very easy to use, as you will see in a second. It's a parametric system, so we can very easily tailor-made it to according to our customers' needs. No installation is needed because it's a SaaS solution, software as a service. And also there is an option to show the location of the user on a map. Let me show you, please, very briefly, a short demo of the system. So this is the dashboard of the doctor. He can see last locations on a map and on a table, on a graph of daily calls. When somebody is calling to the hospital and the doctor feels that he wants to have the patient online on video, he just sends the user a link via SMS or email, and in the near future also WhatsApp, and he starts a video session. From the side of the user, he gets a link.
No, we cannot see. We see only your slide. We don't see any screenshot.
Okay, thanks for telling it to me. Can you see my screen now?
We can see your lovely face.
It's nice, but not enough. How about now?
Yes, now we see the remote doctor. Yes.
Okay.
Which is the app.
Yes, so this is the customer gets a link that he is opening from his browser with no app involved. This is not an app. This is just the web browser on the patient's smartphone, and he can join the session with this handsome doctor. He can watch documents that he got from the doctor during the conversation. He can upload his own files from the camera or from the device. He can chat with the doctor. He can add another participant to the conversation, like a family member or the family doctor. This is from the side of the user. From the side of the doctor, this is the dashboard, as I mentioned before, where he can see last locations on map. It's not mandatory, but it's an option to send location. And when the doctor calls the patient or joining him on a session, this is the dashboard for a live session where he can see the video and the location, and he can write comments, and he can see the documents were sent by the user, and he can upload his own files, and he can add another doctor, another expert doctor to the conversation. So this is the live session area. But our system is not only for live sessions, it's only for manage and control the history. So all sessions are recorded and stored on our customer's cloud or server. So it's on the hospital's cloud. And the doctor can go to any historical record from yesterday or last week or last month and watch again the video and watch again the comments and the files and even share it with another doctor. So this is very, very briefly our system. If you want to have more details, I would be happy to
Is it already operational?
Sorry?
Is it already operational in Israel?
So we just launched it actually this week. We have a few customers, both in Israel and worldwide, that already starting a short period of free trial in our system before hopefully turning into real customers.
Okay, so maybe post our session today, you'll have customers in India. So that's the meaning of that. Naveen, would you like to take the Q&A part of this webinar?
Yeah. So I have received a couple of questions on Facebook and a couple of questions on this webinar panel as well. So I just received one question. So there is one question from a Facebook user. Can you please share COVID and non-COVID flow chart in hospital infrastructure management?
That's a tough question, I would say.
Yeah. So one or two lines would be better. I mean, how we can, although, Osnet has told us that how she's doing in her hospital, still one or two lines for this user would be good.
Dr. Levtsin, have you understood the question?
Yes. The idea is what we have to do is you have to, for the patient flow, there's the in and out. And the idea is we don't want patients going in background, and we have to, the flow has to be separated from the regular flow of the patients. So if it's the emergency department, we start from the triage. We start from where the ambulance is bringing patients. He's bringing the COVID patients to a different area than the regular ambulance, than the regular patient. And then there's the whole process, who takes the test, the COVID test, where do you put them? And you have to really walk the walk. You have to walk the walk. That's how we do it. And to see that once you practice, once you plan it, you have to minimize contacts with either staff or other patients. You can use also, like Ellie said, all different kinds of structures and doors that we built, overnight. Ellie and his team built it to be able to really separate it, so no one by mistake will go into the corona area. This is for the emergency department, but the same principles guide you, whether it's the ORs or stuff. What you need to do and minimize contacts.
Got it. So there is another question by Rachna Trehan. She's talking about testing rates per million population in Israel. I know about India that although we are testing very less, our figure is somewhere between 220 to 250 per million population testing. How about Israel? I mean, I know you are testing much more than us, but
and we complain that we don't test enough. So, Osnat, can you elaborate on that?
Yes, I think first of all, we all need to remember the limitation of the testing. The tests are very limited. What they're doing currently is the RT-PCR. They need the viral load. You need a viral load to be positive. So it's not serology, and it's very. We know that there is a false negative. So the test is not very reliable, and we see it all the time.
Yeah.
At first, the indications were very limited to those who were exposed to either came from abroad or exposed to someone with COVID-19 or etc. But then now the indications have really were extended significantly in a way that we do testing in our hospital, and I see that every day we do hundreds, and then we see one or two positive results. There's also the question whether to start screening all elective patients. Sorry, this is at the time where you already have enough tests, because if you don't have enough tests, you have to think very carefully who you're testing, and not just be very wide and very open, generous about it. Because and we know that the other thing that about testing elective patients or patients who are not really risk is that the other thing you don't want is you don't want the staff to have false assurance that the patient is COVID free. Because sometimes he can be sick and you won't know it, and you will still and you'll think, oh, he came out negative in the test, so I can take out the protective equipment, and that's something which is very, very important.
Yeah, got it.
Thank
So,
you. Just a sec, Raviv, you had a question to Anjan earlier.
no, I think we are done with the question. Then Anjanda had some problem in his, his laptop hang, and so I think
I don't know if I'm audible. I'm connected by mobile now. Am I audible?
Yeah, very much audible, Anjanda. You are very much.
I can answer. So if you have any questions.
So I think we have stretched this session a bit, and we took liberty to stretch it further to 30 minutes, and we have, although this session was for 60 minutes, and this was such an interesting session that we couldn't stop ourselves. And Anat asked me that whether we can extend this session. I said yes, we are doing good, and we should extend this session. And I'm really thankful to all of you. Anat, do you have any question to any of the panelists here, or you want to say something here?
No, I think that this is the fact that our session was extending means that there is an interest between the panelists and with the audience that are bringing questions. Yeah. And I think that we should have another session and another discussion how we can work together, not just exchange notes, but really learn from each other best practices, best technologies. We are learning on the go, as everybody says here. And it's better to learn from each other and not learn only from our own circumstances.
Absolutely.
So I'd like to thank you.
But one thing I want to add, Anat, I was impressed by the PPE suits where the photograph of a doctor or a paramedical worker is there with a name. I think that is, but everybody wear this PPE. You find they are in the space. You don't know who is who. So that is a very good thing. I think we can do the benchmarking in our hospital as well. That's good part of it.
Wonderful. Anat? So thanks for Voice of Health for this initiative and asking us, the India-Israel Chamber of Commerce and the Israel-Asia Chamber of Commerce. I'd like to thank the embassy in New Delhi that made the contact, and for you, Mr. Granot, and your team for initiating it. I'd like to thank the Israeli panelist, Professor Ifergan, and Dr. Osnat and your team. Thanks for taking the time in this hectic Corona era to join us and share your experience. It's really appreciated. I'd like to thank Unishal and Anjan Bose and Mr. Niraj Lal for joining us today, as well as the two technology companies that joined us. So thank you all. God bless you. And I hope that we will meet in quieter times in our lifetime.
Yeah. So we should connect offline as well. And now we know each other. So
we'd love it.
Hopefully, we would meet very soon.
Thank you.
Thank you, everyone.
Thank you. I want to wish you everybody stay healthy and stay positive.
Thank you very much, Neeraj.
Thank you.
Thank you very much to everybody for joining.
Excellent session.
We really, really appreciate all you.
Thank you, Anat. Thank you very much. Thank you, everyone.
Thanks.
Thanks.
Bye-bye. Bye-bye.
Bye-bye.
Bye.
Thank you very much, our viewers. I'm really thankful to you. Thank you very much.
See you. Thanks, Naveen. Thank you. Bye-bye.
Have a safe stay.